Well, good afternoon. Thanks, Krish and the organization for the invitation. It is a pleasure for me to be here and talking about such an important topic. It is teaching robotic lobectomy for residents. This is a topic that has been discussed in our robotic committee at the Brazilian Society of Thoracic Surgeons. So it is very adequate to discuss this here too. These are my disclosures. I'll start saying that it's a privilege to teach residents. It is an extremely rewarding, though challenging, endeavor, and it's been changing a lot over the last 10 years. If you see in this picture, I'm teaching one resident to perform an open lobe. This was in 2009. At that time, it was very comfortable for me to teach residents because I was just reproducing something that I was already taught in a very organized, in a very standardized way. I had also my both hands there, so I had a lot of control over the procedure. This is in 2014, and then things changed. Our staffs were already trained in video-assisted surgery, and we decided that we should teach residents to perform video-assisted lobectomies. And then I wasn't that comfortable anymore because I was teaching something that I wasn't formally trained to do. So I learned over the years, and there was no standardized curriculum at that time, at least in my country. And I also had not that control as I used to have with my both hands in the surgical field. We felt that it would be very important to teach residents, and we learned that most of our surgeons, fellow surgeons in Brazil, didn't have any sort of training on that, and that was the reason why they weren't adopting minimally invasive surgery. And then we carried out later a survey amongst our members, and we really demonstrated that lack of training was the reason why most of those who were not performing VATS did not adopt VATS. We designed a course, so we discussed a lot how we would have an organized curriculum, and we were, through the Brazilian Society of Thoracic Surgeons, training residents on how to perform at least the basics of video-assisted surgery. So we developed a new curriculum, and we learned how to teach residents VATS, and we thought we had all the answers, but then again, questions changed. And so now we have this scenario in which we have to teach residents a new technology, and it's always challenging. But the difference is that now robotic surgery arises in the scenario with more structured training. So this was already discussed. I think we learned a lot with the process of teaching VATS. And this is what we have now. We have many resources for online education. Simulation is much better with the robot. It's very realistic. Well, we also always have to perform the supervised procedures. We have more standardized evaluation system and also a process of credentialing. Robotic lobectomy in particular is a more advanced procedure when you are teaching robotic surgery. So because of vascular structures, we see here we are dissecting the pulmonary artery. And so we should follow all the steps with the residents from a regular robotic training perspective. So the online education, simulation, we should start with simple procedures and then move on to performing parts of a lobectomy, and then finally let them pass the behind the artery, as we are doing here, without having a heart attack. And this is the resources we have. You find online education. Intuitive has a very good website for that. And I'd like to highlight this one, that this is the fundamentals of robotic surgery. This is a consensus of 14 societies in which they discussed a lot about how robotic surgery should be taught, and they developed a curriculum based on cognitive, psychomotor skills, and team training. Team training is very important because robotic surgery is about playing in a team, and so it's a fundamental part of the training. And you find in this website several resources, videos, exercises that encompass all these points, the cognitive, psychomotor, and team skills. The ESTS has published last year a consensus in how the curriculum of robotic surgery should be, and all the experts agree that it was necessary to have a basic education that would include, for instance, docking, portal placement, and troubleshooting, basically knowing the equipment, the machine. It's important to know how to clutch, how to use the camera, and so on and so forth. And I think that simulation is one of the greatest advantages of this teaching robotics. It's different from other procedures where simulation is not that good. This is our fellow, of robotic surgery fellow, practicing. We ask them to practice at least 40 to 60 hours before going to the console. It is very realistic, and you have 3 different simulators now. Though the first one is this one is the first one is the integrated to the console. The second one is the Robotics, and the third one is the Mimics. All of them have some peculiarities, but they have the opportunity to practice even lobes, robotic lobectomies. There are modules for doing this. And it is important to mention that simulation has already proven to be a very good strategy to train residents. It has validity. There are many papers in the literature showing that the most they train, the better they get with their skills in the actual procedure. There are other options, wet labs. This is the wet lab we have in our hospital. We developed a model to practice robotic lobectomies in pigs. It's not that easy. It's not that it's quite expensive too, but it's an opportunity to practice before moving on to real cases. The cadaveric training is available in some countries. It is expensive. It is also in many countries as mine not easily available, and many consider that may be something unnecessary. This is the consensus again of the STS consensus, and we see that the experts agree that virtual reality is a very good simulation tool. The dry lab and wet lab should be used, and they were not consensual in terms of the application of the cadaver training. But team training was also highlighted in the consensus. And you can train your resident as a bedside assistant, and so practice docking and many things. But you can also train emergency scenarios, how to undock, and you don't need to be operating on a patient to practice that. You can use the robot to practice in dry lab in a inanimate model. Supervised procedures should be offered to residents in an increasing complexity. They start as bedside assistants, so they practice docking, port placement, stapling, and after participating in 10 to 20 cases, we feel that they are able to move on to simple procedures like small mediastinal tumors, and then to more complex procedures like parts of lobectomy, like lymphadenectomy, vein, dissecting the vein, and so on. Having a dual console is very nice to teach them because you can pinpoint parts of the procedures, you can, anatomic structures, and you can also take the control of the procedure if you feel there is something dangerous or if they are not able to proceed with the surgery. There is no fixed number after which someone is apt to perform robotic lobectomy. I think this is most of the papers that are describing learning curves try to, like this one, this is a very good paper, but the point is that they just show that the variance decreases over time when you are increasing your experience as well as the number of conversions. But I think that the most important way of evaluating residents is to have a well-structured strategy or well-structured instrument like GEARS. GEARS is this instrument developed that you have like a scorecard, and you give notes, you score the several parts of the procedure, how the resident or the surgeon is using the instruments, the camera, and so you can have a final score, and you can evaluate them over the time. This has been, in a short time, this will be an automated process. This paper is interesting, and the authors evaluated, using machine learning, the possibility of scoring, so the computer scores the resident. And it's very interesting, but at the same time a little bit scary, because the computer was able to predict the outcome of some urologic surgeries. So I don't know how the administrators will eventually use this, but it is a very interesting tool. It was part of the consensus also to describe how, what type of institutions should provide robotic training, and it was consensual that it should be an institution recognized by the society and with at least 50 cases a year. Our program is the only program in Latin America. We train. It's a one-year fellowship after the general thoracic surgery residency. We've been increasing our surgical volume, robotic surgical volume a lot, 160 cases. It's the exposure last year. And the final point I'd like to make about our residents is that we have to learn how to teach them, because there is now a clash of generations. Baby boomers and X generation, they are very similar and very different from Y and Z generations. There is a different attitude towards work, the ability to deal with technology, the globalization. So they have unlimited information whenever they want. And so it's very important not only to pass information, they already have that. It's more to guide and to develop a way of teaching that is fun. If you want to have them engaged, make it fun. This is an example of one competition that this group developed, in which they were, you had like a Top Gun, and then the residents were practicing things, and they were competing between themselves. And then you see that engaging them makes it much easier and results much better. So in conclusion, if you want to teach your residents robotic lobectomy, it's not that different from what we have already been doing. But at least we have a structured curriculum now. So follow this. Basic concepts, this is an online content. You have FRS, you have Da Vinci Community, simulation, and simulation. You have virtual reality. We can use wet lab. You must expose them to bedside experience, because they learn a lot just from watching the procedure, and progressively offer them supervised procedures. Evaluate them frequently using an objective instrument like GEARS, and above it all, make it fun. Thank you.